So my name is Alex Rampotas. I'm one of the hematology registrars in Oxford, and this is an audit that we started locally, actually in Oxford, and we were able to demonstrate in a very small patient sample that if the anemia is not investigated properly, that could lead to further transfusions. So we thought that HaemSTAR is an excellent platform in order to roll this out nationally and see if we can replicate this result to across the UK. So I led this audit. Catherine Proger, who will take over from me in terms of representing Thames Valley and HaemSTAR, was also contributing significantly. It was supervised by Professor McMurphy. So in terms of the background, so what we try to achieve is to assess, first of all, the incidence of transfusion in anemic patients in the acute care setting, and if further investigations of the cause of the anemia could have avoided it. And this is because transfusing blood has been shown in multiple studies that it can cause harm. It's not a harmless treatment that can be employed at any case. So it has to be thought about, and we have to make sure that we're transfusing the right people. And in terms of the investigation, that could uncover significant pathologies such as GI malignancy leading to anemia, and obviously cutting those cancers early can be important in patient survival and outcomes. And in terms of the audit, it involved reviewing the patient's notes, seeing when they received the transfusion, if the transfusion was appropriate and according to the thresholds that have been set out, and if their anemia has been investigated properly, if the cause of the anemia wasn't clear, and then seeing if they received another transfusion in the next 6 months. If we got the and yeah, this audit was launched in Oxford, and we had 15 more centers across the UK, and HaemSTAR helps us a lot in terms of recruiting patients from there. Yeah, if you go the next one, please. So it was collaborated by HaemSTAR. At that time, it was one of the 4 active HaemSTAR studies being run, and 15 hospitals contributed data. We are assessing the appropriateness of transfusion, as we discussed, the appropriateness of the investigation of the anemia, and then we quantified the number of patients with incompletely investigated anemia who received transfusions on more than one occasion. And essentially, if you look at this diagram, so we try to categorize the patients according to the cause of their anemia, and those patients that they didn't have a pre-existing diagnosis, we want to see if the cause of the anemia was identified during the admission, if not, and then if they were adequately investigated or not. If we go to the next one, Emily. And you may be wondering what means adequate investigation. There are some guidelines, and for example, the laboratory investigations that should be done are specified depending on the type of the anemia. So for microcytic anemia, these are the investigations that should be done. Obviously, iron studies for normocytic anemia, B12 and folate, and for macrocytic anemia, you can see those here. And also, this investigation should be coupled with a referral to gastroenterology for iron deficiency anemia, or to hematology for normocytic or macrocytic anemia. If we go to the next slide, yeah. So these are our results. So you can see that we had the median age of 74. And in terms of the cause of anemia, it is pretty much what you expect to find. Like wide range of causes. Bleeding is obviously a big percentage, major and non-major bleeding. The important bit was the unknown cause, which was 18.6%. That was 154 patients. And interestingly, 4 patients weren't anemic. They weren't even anemic when they were transfused, but they still got blood transfusion for non-major bleeding, even though their HB was above the lower normal limit of the laboratory. In terms of the anemia characteristics, you can see that most of the anemia is macrocytic. which is expected because most of the anemias are due to bleeding and iron deficiency. But a good percentage were macrocytic, which usually indicates that there's an underlying significant cause. Could be hemolysis, or it could be MDS or myelofibrosis. And moving on to the appropriateness of the transfusion, although a big progress has been made over the last few years with establishing national thresholds, we identified that almost 20% of the patients in a sample of more than 800 patients, they received blood transfusion inappropriately against the national led thresholds. So this is a quite significant number that probably indicates that there's still work to be done in terms of educating junior doctors, educating A&E staff, and implementing other measures such as electronic prescription of blood transfusions that they can potentially pop up a message saying that, are you sure you want to transfuse this patient because it looks like he's not anemic, or he's not as anemic as the guidelines say that he should be to have transfusion. So all of these are measures that have been implemented in Oxford, and in Oxford have been able to show that it did reduce inappropriate transfusions, and there's a continuous effort, a campaign almost, to implement those across the UK. And interestingly, there were alternatives to transfusion in 31% of the cases, and those could be iron infusion. That's a very common one. Someone comes with a low HP who is iron deficient, and especially women, and they may receive a transfusion. And if you have a young woman at that point, you have potential to cause harm due to sensitization to various antigens that potentially can lead to hemolytic disease of the newborn, or something like that. If we move to the next slide, and yes, I highlighted that there were quite a few inappropriate transfusions. So in terms of the inappropriate transfusions, here the 159 patients, the cause was identified during the admission in 30.8%, while the cause was remained unknown in almost 40% of the cases. And again, you can see here that there are alternatives to transfusion. And right, yeah, and you can see the anemia characteristics, and this is probably the most important bit of the results here, this table, because we started by saying maybe if we don't investigate the anemia properly, that could lead to further transfusions. And unfortunately, we haven't been able to show that, although there was a trend, but it was so small that it wasn't even worth doing a statistical analysis. We end up having a number needed to treat of something like 50 or 60. So we didn't go ahead to perform statistical analysis because the numbers were pretty similar. However, that doesn't mean that we shouldn't investigate an anemia of unknown cause properly, because you may end up with higher mortality or missing an important diagnosis. And also, all of these numbers can be quite biased because for many reasons, especially if you have a patient who has anemia of unknown cause. There could be many things going on in the background. In terms of the investigations that haven't been done, there is pretty much an equal spread. So the blood tests were missed in 37.8% of the cases, which is a fairly big number and quite easy thing to do, really. A specialist referral, which actually can be maybe more tricky in some centers, was missed in 27.7% of the cases. And I guess more dangerously, both were missed in 34.6%. So this highlights that anemia of unknown cause is not investigated to a good extent. And you can see here that almost half of the patients weren't investigated properly. And if we go to the next slide, please. Yeah. So what we highlighted is that the patients who present to the acute care settings with anemia are at risk of inappropriate blood transfusion and inadequate investigation of their anemia. So yeah, more effort needs to be done in order to sort this out really. Um, 90% of the patients transfused for anemia, they didn't have the cause of the anemia identified by the end of their admission to the hospital. So that's a big number. And almost half of them, they weren't investigated properly at a later setting. This study is another study that was conducted by HaemSTAR or with the continuous support of HaemSTAR, and it does show the importance of collaborative support in facilitating these large audits with many patients. And also it highlights that once you level up an audit to a national scale, the small signal that you find in your local center may not be replicated. So that highlights the importance of having a large patient cohort. That was presented, the ARIIA was presented as an e-poster at the BSH meeting in 2020 and has currently been submitted for peer review and a publication, hopefully in Transfusion Medicine. I would like to thank everyone that was involved in the data collection and HaemSTAR for their support and advertisement of this audit. And if we go to the last slide. So if you want to get involved, we do have another audit that it's open at the moment. We are investigating how ITP is managed in the COVID era. There weren't really guidelines, but there was some sort of practice recommendation on BSH from BSH about how ITP should be managed in the COVID era, such as avoiding steroids. And we want to see if that has changed the practice. So if you want to be involved in this audit, you can contact either me or my colleague, Ed Watson. And essentially, if you do have any cases of ITP since the COVID pandemic started, you can enter them using the link that is on this flyer. And that will be all. Thank you.